to our breakout session on brain metastases. My name is Beth Caldwell, as you know, and I have brain metastases myself. In fact, I just had an MRI yesterday that looked pretty stable, so that's good news. So, hoping the same for all of you guys. So I'd like to introduce the folks who are here. We're going to be speaking today about brain metastases. So, our first speaker is Allison Conlin. Allison is a physician and researcher at the Providence Cancer Center in Portland, Oregon, so we're excited to have you up here from Portland. She's a medical oncologist who directs the breast cancer program in medical oncology at both Providence St. Vincent's and Providence Portland Medical Center. She specializes in the treatment of breast cancer and other high-risk breast conditions and completed her fellowship training in 2008 at Memorial Sloan Kettering. And she also has a master's degree in public health from Boston University, and she has an interest in clinical trials for patients at all stages of breast cancer. She's written a whole bunch of stuff, and she's really fantastic. Sorry, I'm going to skip through your bio. Next up we have Dr. Leah Hallis, who happens to be my radiation oncologist for my brain, did my gamma knife. And we also went to middle school together. Of all the random things we found out, when I had my gamma knife and my hole started bleeding, and she was holding a towel, she was like, "Oh, so are you originally from here?" And we discovered we went to the same middle school, so that's fun. And I totally looked up your middle school picture and mine when I got home. I was like, "Look at us! I had terrible acne and whatever." All right, so she is a radiation oncologist who specializes in caring for patients with brain and spinal cord tumors at UW Medical Center and SCCA and at Harborview. And she's an assistant professor of radiation oncology and neurological surgery at UW, and her clinical interests include gamma knife, radiosurgery, and proton therapy. And I want to talk to you more about proton therapy because I don't know much about it. Her research interests include clinical outcomes and comparative effectiveness for patients treated with radiation therapy for brain metastases. And then finally, our last speaker, and tell me again how to pronounce your last name? Loisel. So Chris Loisel, Dr. Loisel is a board-certified radiation oncologist practicing at the Cherry Hill campus for Swedish Medical Center here in Seattle. And he went to Johns Hopkins School of Medicine and completed his residency at the University of Washington in Seattle Cancer Care Alliance. Chris specializes in the treatment of complex cancer situations, including brain and spine metastases from breast cancer. And when he's not at work, he's probably outdoors in the Pacific Northwest, as many of us are, but not today, trying to keep up with his wife and kids. So everybody, let's give a round of applause for our speakers.
I just wanted to talk about this approach from medical oncology. We're so lucky to have two different radiation oncologists talk today, and my viewpoint might be a little bit from a different angle there. So I just put a little background that brain metastases, if you look in autopsy studies, might be as much as 20 to 30% of patients with breast cancer. Certainly, we see it at about 10 to 16% clinically apparent, meaning coming up with symptoms, but the other 15% may be people that don't know they have it. So there was one very famous study where we were giving Avastin to women with metastatic breast cancer, and we screened every woman beforehand and found it was a much higher rate than we thought. We think about brain metastases in women with HER2-positive cancers or triple-negative cancers. Those are thought to be maybe more common. However, if you look at the numbers, since it's just more common to have an estrogen-positive cancer, the luminal B subtype might be actually the most numeric. So it's really relevant for all the different subtypes, as I know you heard a little bit about this morning. Common sites would include all the parts of the brain stem, the front of the brain, the back of the brain, the balance center, the cerebellum. And breast cancer is thought to be the most common solid tumor to go to the leptomeningeal area. That's the fluid around the brain and the spine. And of course, why we care about it, as we care about many things with treating cancer, having brain metastases can have a lot of what we call morbidity or symptoms, like changes in your mental status, how awake you are, how you can think, headaches, seizures, weakness of a certain area, or nausea. So this is an area that needs to be addressed right away because of how critical that area is for our function. So some of the things it made me think of when I was thinking about this talk is what some people presume or assume, which may not be true anymore. For instance, when diagnosed, it's a poor prognosis. You're going to die right away. And we know that. There are people sitting here that that's not true about. And in fact, the radiation oncologist developed this great index called the Gpa Index, where you can put in just a few pretty apparent factors and actually sort of share with your patient actually the median survival, and of course a median is an average, and that's not useful for every person. It might be 23 or more months. And so it's really not super accurate to say anymore it's poor prognosis. Obviously it's a serious event for patients, but maybe not as bad as we thought it has been. Symptoms are too hard to manage. That's not true at all. Now we have great strategies to manage all sorts of symptoms. more than once I've put in my talk the use of palliative care services in addition to our oncologic care services. It's great to have folks who are focused in how to manage either the numbness, how to manage the difficulty walking, occupational therapy, physical therapy, so many ways to make people more functional. So that's great. And not much research must be done, so that it must be not an option. And that's not true either. Even with leptomeningeal disease, which has typically been a big exclusionary criteria for doing research, I'm seeing protocols for that come across my desk regularly now. So I think research is more common. This has been thought of as an unmet need in breast cancer research and treatment, and we're finally getting the attention, which I think is terrific. So I don't really have time to talk about all treatment options, but of course, we start with thinking about all those supportive measures. If you need anti-epileptic drugs to prevent seizures, steroids have been a mainstay in preventing the swelling, and the palliative care team. We don't have someone talking about surgical resection, but sometimes that's the right answer for patients. I'm not going to talk at all about the radiotherapy, the gamma knife for the whole brain, but I do want to touch a little bit about the intrathecal chemotherapy. That's giving chemotherapy straight into the spine. Not used very commonly, but actually is getting more and more research behind it. I have a patient right now responding beautifully to it and doing quite well, and her symptoms have improved with it, which I think is kind of remarkable. And systemic therapy is really what we do the most in oncology. It's giving chemotherapy or targeted therapies that we hope can reach those areas. So again, really mainstay of treatment has been radiation, whole brain. I don't really want to go over this too much, but it's been known to relieve symptoms, improve survival, show responses. But women lose their hair, feel tired, maybe have some cognitive dysfunction. So I know our radiation docs both here are very focused on using gamma knife and SRS, more focused radiation, and that might be appropriate for more people now than ever. So what are our challenges with using systemic therapy? We know when we're treating the bone, the lung, the liver, what people will hear about a lot in the other breakout rooms is the fact that chemotherapy goes everywhere. But our challenges in the brain is often poor penetration of drugs. Our brain works really hard to keep bad stuff out. You know, we don't want toxins to go in there. So number one, some of these drugs are very large. The most famous one might be Herceptin. Herceptin's a big drug, not thought to get well into the brain, although there is a lot of research about the penetrance of those drugs after either radiation or having the metastasis itself cause holes for the drug to get in. And then there are actually little mechanisms on the cells of the brain that shoot out the drugs, so little like pumps and things that try to prevent these things from getting in. So some of the old examples of research done, and really the existing literature is not super fabulous, are maybe using cyclophosphamide or high-dose methotrexate in the blood so it gets into the brain, or Xeloda is a very common one, or temozolomide, which is used for more brain tumors. But the response rates I have up there either vary, 17 to 54%, that's a pretty wide range. I'm not sure if I talk to a patient like that, that would really help them make a decision, or pretty low, 18 or 20% are not very high responses in breast cancer. We really aim for higher numbers. We talked a little bit about the intrathecal methotrexate. I don't have a number up there because in breast cancer there's not been a lot of focused research using just that. It's been more case reports. So there are some newer options. Targeted therapies have been our option that you've heard about a little bit this morning because of looking at gene mutations and ways to target drugs, and perhaps our smaller molecules which might more easily get into that brain area. So I mentioned that trastuzumab or Herceptin being a little bit large, and when they look at basically your blood versus your brain ratio, it's too big of a number. That shouldn't be 700 or 400 to 1. It should be a lower number. Maybe radiation helps that out. Lapatinib, Tykerb is a smaller molecule. That was a pretty exciting thought back when it first came out for brain metastases that were HER2 positive. But the response rates have been in the lower end, and we've still managed to use it a lot. Many of those patients, though, of course, had prior whole brain first. There are newer drugs. A new drug that's actually from a company up here in Seattle, just got a name. It's called tucatinib, or ONT-388. We have done several trials on that. I've been part of the phase 1 and now the phase 2. And that's showing a lot of benefit for patients. In patients who've never even had whole brain, it was showing a 44% response rate. And for those who had already progressed in the brain, giving it actually showed response. And those are all in HER2 positive patients. So I'm not really going to go over all the drugs, but I wanted to mention to you some of the examples of where we're trying to go and just give you hope that we're moving in a better direction. So with that, we'll talk a little bit more about the radiation. We'll let questions come at the end on the cards.
Okay.
So I want to thank the organizers for having me here this morning. I actually just put together a few background slides. I think Chris will get a bit more into radiation. So some of it may overlap with Dr. Conlon's, but kind of how I look at taking care of patients with brain metastases. So first of all, just kind of thinking about how common are brain metastases. There's basically estimated about 5% of all women with breast cancer have brain or spinal cord metastases. And 14% of the women presenting with metastatic disease. So if you have metastatic disease, you're more likely to have brain metastases. Overall, the incidence of brain metastases is more common in HER2-positive patients, but that's actually before they had trastuzumab. So basically, before they had trastuzumab, it was quite likely that patients with HER2-positive disease had brain metastases, but after we had this drug and systemic therapy, it went way down. And I think that's just important in thinking about our patients and what Dr. Conlon was saying about targeted therapies. Triple-negative patients where there's no staining for ER, PR, or HER2 also have a higher risk of brain metastases, and then patients with lung metastases. Because the thought is that the cancer cells circulate through the blood, and one place that the blood goes up to the brain, and that's perhaps how things spread. So how do brain metastases form? It's actually a very active area of scientific discovery. Why does a cancer cell decide to lodge in the brain and create a tumor? We don't quite know. Most commonly, it's thought to be through the blood flow, but there's also some metastases that have direct extension through the brain tissue, through the spaces that kind of are around the nerves and vessels. And there's some question about whether when you do surgery that there may be some seeding along where you do the surgery tract, but that's kind of an open question. So overall, this is just a picture of the brain. And the cerebral hemispheres is the main part of the brain that's kind of colored in this area. And that's where most brain metastases are found, probably because of the blood flow and how it gets there. The cerebellum, which is in the back and the bottom part of it, also there are brain metastases. And then the brainstem, which is sort of where all the nerves come down from the brain down to your spinal cord, that also is a place where there are some brain metastases, but less often. So as Dr. Conlon talked about as well, treatment options, we talk about supportive care, surgical resection in some situations, radiation therapy, which there is whole brain radiation therapy where we treat the whole brain. There is also stereotactic radiosurgery, which is a more pinpoint treatment on each brain metastasis. There's also chemotherapy, targeted therapies, and in the future immunotherapy, which seem to have some response. And I will touch less on that, but those are all options overall. So when is surgical resection used? So surgical resection can be used especially if there are just a few metastases or one metastasis. It is very helpful sometimes when you're not sure what the diagnosis is. Most of the time, just the vast majority of the time, we can diagnose based on MRI and the fact that a patient already has breast cancer. But there are some cases where there are new diagnoses or things like that where it may be important to get tissue. Also, if there is a metastasis that's so big it's causing a lot of symptoms, surgery is really the only way to quickly, not the only, one of the best ways to quickly get out something that's large and causing a lot of symptoms. So you'll see surgical resection used quite a bit in more urgent situations or in large metastases. And then finally, single metastases. So there is some thought about using surgical resection if there's only one. Though radiosurgery is often used as well, and there are some trials that look at that, but no kind of head-to-head comparison between surgery and radiosurgery for a single metastasis. Whole brain radiation therapy used to be quite the standard of care for many years. It still has a role in multiple brain metastases, often in involvement of the leptomeninges, which are the covering of a brain. The pluses about whole brain radiation is it treats all the metastases you can see on the MRI, but as well as metastases that are too small to see on MRI. And really, it was started, in the 1960s to treat palliatively. So patients who had symptoms from their brain metastases had improvement with whole brain radiation. That conversation changes a bit in the new era because we actually are treating more and more patients who don't have any symptoms, who really come because of brain MRIs and a lot of imaging. So this is just kind of a photo of a whole brain treatment where we basically outline where the treatment is. We give the treatment in about 2 weeks, and we give a little bit of dose per time, but really treat that whole brain. And then stereotactic radiosurgery, first used in the 1980s for brain metastases. So I put up kind of pictures of all of our machines because I think that we tend to, well, the companies tend to like very sort of catchy names. So you've heard of Gamma Knife, you've heard of CyberKnife probably, but there's also linear accelerator all the way on the left type of radiosurgery, and sometimes protons are used for radiosurgery, although we don't. But I put this out to say that actually all of these machines do what we call stereotactic radiosurgery. So they don't have any difference in clinical outcome. They have some pluses and minuses from the planning perspective that we do as radiation oncologists, and also from the perspective of how we immobilize a patient or keep them still. But you may see different radiation oncologists and they have different machines, or they may have all and kind of choose between. But any of these things is stereotactic radiosurgery. So over time, just to give kind of a brief history, there have been a lot of trials looking at stereotactic radiosurgery and whole brain. But when I think about how it's historically happened, is that over time, when they started with radiosurgery, they thought, okay, we can add this to whole brain radiation because everybody was getting whole brain radiation. So they added it to whole brain radiation and found it may help people who just have one metastasis. But then they started testing, okay, can we use it instead of whole brain radiation? And those are sort of the more current trials that showed that really it was no different to give whole brain radiation or just radiosurgery without whole brain radiation for patients with a few mets. And then it's been used more and more as our technology improves to treat patients with multiple metastases. And recent trials have really looked at the effect of whole brain radiation on long-term outcomes, so I think it's been used more and more. Really, a lot of the recognition too in our trials have been more looking at the quality of life and neurocognition that comes with the radiation. I think previously trials really looked at how long people lived, and now we're really refining that to think about the important outcomes for our patients. So for breast cancer patients, it's been increasingly used for patients with multiple metastases, especially because breast cancer patients have better prognosis on the whole than many patients with brain metastases. Our group, for instance, did publish on our experience with treating patients with gamma knife radiosurgery and found that many patients benefited even if they had multiple metastases because patient survival was much longer than we had even supposed. And then finally, systemic therapy. I'm going to skip this slide because Dr. Conlon already talked about it, and I was just sort of updating all of the different avenues that are really being studied and looked at, because I personally think that systemic therapy is going to be very important for our patients with brain metastases, and it's important to work very closely with our med onc colleagues. So finally, in conclusion, I think there actually will be increased treatment with radiation with our better systemic therapy. I think patients are living longer, we're finding metastases sooner, and having some local control is quite important. And then it's very important just to really think about the side effect profile and quality of life that occurs with our treatments. And so with patients with 1 to 3 brain metastases, trials have really shown that adding whole brain or not really leads to overall survival, so we really need to think about our quality of life outcomes in the end. And that's kind of what I have as introduction. Oh, there it is.
They're next to the current slide there. I'm Chris Loisel, I practice at Swedish. Good morning. And it's hard to go third, so I thought I'd try to take a slightly different tack and talk about radiation in general a little bit. And so I want to talk a little bit about radiation in general, and then I want to talk about the treatment of brain metastases. And who here is interested in natural therapy for cancer? I am very interested in natural therapy for breast cancer. And I would like to ask you the question, what is more natural than radiation, right? From the dawn of time, we have evolved in the background of massive doses of radiation. right? We get it from the sun. We get it for breakfast, right? How many people had banana this morning? How many people are aware of the amount of radiation in a banana? Unaware. So interestingly, element number 39, potassium, right, the symbol K39, there's a naturally occurring isotope of potassium, it's K40, and it's distributed throughout the universe. And a small fraction of all of the potassium in the universe is actually this radioactive isotope of potassium, K40. So I'm going to give you a little quiz. Well, maybe I won't give you a quiz. Maybe I'll just talk you through a few radiation facts so that you all are as comfortable as we are with the idea of radiation for brain metastases, because really, radiation is the only non-invasive, effective treatment for breast cancer brain metastases. It's the only one. So, you know, when you think about living within 50 miles of a nuclear power plant, you have a certain exposure from radiation. It's about 0.09 microsieverts per year. And, you know, interestingly, you might think differently, but living within 50 miles of a coal power plant, you see 3 times, so order of magnitude difference more radiation from the isotopes released by the byproducts of burning coal, right? So living close to a nuclear power plant, less yearly radiation than a coal plant. But even flying cross country, you see orders of magnitude more radiation there. But here's the most interesting thing. The yearly dose from natural potassium in our body dwarfs those exposures. So significantly more than you might think. So I'm not going to spend any more time going through that. But just remember, there's more radiation around than you might think. So how does radiation work? A lot of patients say, how does radiation work? And what radiation does on the most basic level is it breaks DNA. So it destroys the proliferative capacity of malignant cells by damaging the DNA intrinsic to that cancer that's driving proliferation of those abnormal cells. And well, Leah laughs at this. There's a little bit of an inside joke here about this. And if we have more time, we'll get back to this, okay? If we have more time, just to tease you. Okay, so treatment options for breast cancer. There are basically 2 spots, and forgive me for being a little redundant, but Leah and I didn't coordinate on what we're going to talk about today. But basically, option 1 is treat the cancerous spots in the brain, and we call that stereotactic radiation. The second option is to treat the whole brain with radiation. And my talk today is basically geared to rail against the use of whole brain radiation as if it is the standard of care. Because it's no longer the standard of care. And somebody is going, well, we'll get back to that too. I see a lot of patients and I take care of a lot of women with metastatic breast cancer and brain metastases. And this goes on for years. I've been practicing at Swedish for 6 years, and you know, each year accumulate more and more patients with metastatic breast cancer. And there are, you know, in terms of how these women are doing in their lives, there are basically 2 groups. There is a group of women that have had whole brain radiation and who are suffering short-term memory difficulty years later. And there are those who haven't, who are at work, who come and see me, who have their running shoes on, and who are engaging in life in a way that you would never know that they have breast cancer. And you know, this week I saw one of these patients that I see frequently, well, you know, every few months. And she had whole brain radiation at another center. And every time I see her, she comes in and she says, is there anything that can be done about my memory? And it's interesting because she has introspection into the fact that she has memory difficulty. But ironically, she never remembers our conversation, right? She comes with her husband, and we have the same conversation almost every time that I see her. And this is a consequence of having whole brain radiation about 3 years ago, because she had 7 brain metastases. And what was the point of that? Why not treat those 7 brain metastases? Let her come back for follow-up. If she develops more, we'll treat those then. 2 strategies, treat the spots or treat the brain. And then, there are third-tier options, right? I mean, this isn't, life doesn't split into a dichotomy of whole brain radiation or stereotactic radiation. I mean, there's a whole sphere of other things going on as well very often. The key issue with treating the whole brain is impairment with short-term memory for the rest of your life, and it tends to get worse. It never gets better. Historically, cancer patients did not live long enough for this to be a concern. And this is no longer the case, right, for metastatic breast cancer, right? So we all need to step up and say, women with breast cancer live long enough that whole brain radiation is not a good idea unless there's no possibility of avoiding it. So in our group, we view stereotactic radiosurgery, treating the spots, as the standard of care for women with brain metastases, breast cancer. We reserve whole brain radiation for the following situations most commonly. So really high volume symptomatic disease, leptomeningeal disease, which is cancer spreading to the lining of the brain, disease really socked in around the optic nerves and chiasm, which can't be treated safely with stereotactic radiosurgery, or a concerning level of disease in the brainstem. So, I'd like to make the point that I believe that the number of brain metastases is no longer relevant in determining care. I see all of these guidelines which say, for patients with 1 to 3 brain metastases, do this. For patients with 3 or more, do that. For patients with 4 or more brain metastases, do this. And my inclination is to just, la, 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 la. I don't want to hear any more about the number of brain metastases, because we know that the number of brain metastases is entirely irrelevant versus the volume of metastatic disease, right? Think about it. If you have 1 tumor that's the size of a grapefruit in your brain, you have a different problem than if you have 8 pea-sized tumors. It's totally different. The number of brain metastases is totally irrelevant, and I don't want to hear about it anymore. The other thing is that, as you mentioned earlier, if you screen people with MRI, you're often bound to find brain metastases from metastatic breast cancer. So in trials like thinking about putting patients on Avastin, there used to be a concern for bleeding risk with brain metastases in the brain for patients who were going to go on Avastin. Now we know that it's safe. It's really not an issue. The stroke risk issue is not what it was thought to be. It might actually be protective from stroke. When we're thinking about this number of brain metastases, this is from an era where we didn't really have MRI. We were using things like, rudimentary CT, plain films, and saying, okay, we can see 3 brain metastases. And, these are old studies looking at these cutoffs for the number of metastases. I think it is totally irrelevant in the modern era. Volume of disease is a reasonable consideration. So, I've run out of time. I think that treating the spots with radiation is a better idea than other things. And I think that if you knew how much radiation was in a banana, if you were coming to have radiation for brain metastases, you'd be a lot less intimidated.
That was fantastic, you guys. Thank you so much. All right. So who has questions? Did you write any questions, or do you just have some questions? Go ahead.
Yeah, just nobody's really talked about how often there's reoccurrence. I just had
Should we
gamma
sit
knife.
facing this
I was
way?
going to say, come on up, folks. Yeah.
With gamma knife for multiple metastases. It really depended partly on the type of tumor and whether it was ER positive, PR positive, or triple negative in terms of how quickly patients came back to have gamma knife again. I think our average was about 5 or 6 months, although there were many patients who were much, much longer than that, and it was shorter for patients who had triple-negative disease. So I think it has, personally, I think it has a lot to do with the systemic therapy that patients are on and whether that's working. I always say that my job is to protect the brain and protect my patients from getting neurological symptoms and that sort of thing, but really the heavy lifting is the systemic therapy for the whole cancer.
I think that's where the focus, our current protocol concept in the SWOG committee that Dr. Graylow and I have worked on is thinking about after the SRS is done, after that Gamma Knife is done, how can we protect the brain better? What therapy can we change people to that might be more penetrant? There's some really great researchers looking at levels in the brain of what drugs get there, and there are some misconceptions, like some of the things I even said, like it's too big, it won't get up there. It turns out that TDM1 probably does get up there more than we think. That's a big molecule. So I think we're trying to think better about, rather than saying, oh, you've had a brain metastases, you're out for good, which used to be the case with clinical studies, now saying, oh great, we have a cohort for you. We'd like you to be in our trial because we'd like you to get our drug we think goes up there and keeps you protected. So the same idea of what you guys are doing is saying, I want to get at what you guys have you have the least symptoms possible from the treatment and from your actual disease, and then protect you ongoing. So I think we'll see those numbers get longer the more we understand which of our systemic therapies work better in the brain.
More questions?
May I add one thing?
Yeah.
I think that there are two reasons why more brain metastases develop. And the first reason is that there were some there already that you couldn't see, right? And those tend to develop over the next 3, 6, 9 months. And so after we do treatment, we often watch pretty closely, particularly for that first year, because what you're worried about is there being some that are under the radar. But then, once you get to be about a year out, the development of new metastases will track more with the development of metastases elsewhere. So things will start to move in parallel with what's going on, say, in your liver or your lungs or your bones or your lymph nodes.
So you might be able to do less frequent MRIs at that point.
So what we
just
usually
save
say
it
is
for when-
we'll follow people pretty closely for a year, every 3 months. And then once we hit a year, if everything from here down is going great, we'll actually space it out to about every 6 months, unless something new happens. Unless someone develops something new in the liver, then we'll actually reel it back in.
Are there, sorry, but one more follow-up to that. Are there some scans that pick up more than other scans? Because when they first caught it, they said, oh, you have 3. And by the time I got my Gamma Knife, they said they treated 6. And I thought, wow, that changed quick. Is it growing real fast? Or is it different scanning sensitivity?
So for Gamma Knife in my practice, I do add extra gadolinium and sometimes get thinner slices than what is in a diagnostic scan. So I routinely tell my patients, we may end up treating a few more on the day of treatment, and it's not because anything changed, it's because it's my job that day to bring out whatever's there as much as possible. And then we're always, as Chris talked about, are going to be missing things that are hard to see. That is just the nature of the images that we have. But it doesn't always mean that things have changed quite a bit. It just depends on your protocol, partly.
And to that I would add that there are 2 factors in play. One is technical, and the second is who's looking at the scan. And so folks who live a little bit far away say, can I get, a scan in Mukilteo? There's an imaging center right down the road. Can I get my scan there? And generally the answer is no, because we get, scans that, slice every millimeter through the brain. We get scans with more and better contrast media. And we use techniques like fat saturation to really accentuate and draw out the ability to detect small metastases. And then the other thing is that having your scan read by a diagnostic radiologist who's a neuroradiologist makes all the difference in the world than having it read by someone who, you know, is looking at a mammogram and then looking at the x-ray of somebody's hand and then looking at a chest x-ray. I mean, going to a center where you have dedicated neuroradiologists evaluating brain MR, and you know, they're not only evaluating the brain MR and seeing the and you know, writing this report. You know, they're involved with the design and the application of scanning protocols for your study. So it's not, you know, a brain MRI is sort of one size fits all as you might think.
And I'm afraid our time is up, but I would like to thank everybody for coming, and for our folks at home, this will be online later. So if you have questions, I'm sure the docs are happy to answer them, especially today at lunchtime and during our cocktail hour. They will be around, I think, and can help answer your questions about brain metastases. So thanks, everybody.